Hello, I'm Carl Svedberg from Gothenburg, Sweden. This is EHJ Today. I am at the ESC Congress in Rome, and with me is Lars Valentin from Uppsala in Sweden, an old friend and colleague, and Marco Roffi from Geneva. Lars, you have been presenting in a session called Lifetime Perspective and discussed 15-year follow-up results from the FRISC-2 trial. Can you give a background to summarize the FRISC-2 and what you have done here?
Yeah, the FRISC-2 trial was a randomized trial of patients with non-ST elevation acute coronary syndromes. These patients were recruited between 1996 and 98, so that's 20 years ago. At those times there were no recommendations for early invasive treatment in acute coronary syndromes because there were no evidence. There were several controversial findings in other trials, but the FRISC-2 trial then randomized patients to early cath routinely in everybody, and also with a procedure on all significant lesions, and that is PCI at 1 or 2 lesions, or CABG surgery at 3 vessel disease or left main disease. And this led to 80% procedures in the early cath population. That was compared to a group randomized to an early conservative approach, and with that approach cath was only performed if there were severe remaining symptoms of ischemia or severe ischemia at an exercise test. Otherwise, these patients were conservatively managed, and this led only to 13% procedures while in hospital for the non-ST elevation acute coronary syndrome. And the initial follow-up was for 6 months, 1 year, and 2 years. And at 1 and 2 years, there was a significant reduction in the primary composite endpoint of death and myocardial infarction. And there was also a reduction in mortality at 1 and 2 years alone. So these results led to changes of the guidelines. They were later confirmed in the Tactics Team 18 trial from the US, in the RITA-3 trial from the UK. It was also recently confirmed in aged patients above 80 years of age in the Norwegian elderly trial. There was a neutral trial, the ICTUS trial, where there was though a lot of crossover because the FRISC-2 results were already known at that time. So what we did now was really to look into what might be the lifetime consequences of these early benefits. And we did that based on the Scandinavian registries. So these patients were recruited only in Sweden 80%, Denmark 10%, Norway 10%. Where we are able to merge based on the patient's identification number with all readmissions to hospital and of course mortality data over time for up to 15 years, minimum 15 years. And of course, when you have this time of long-term follow-up, you have to realize that there is crossover between the groups. So there were, after 2 years, 50% revascularized patients also in the control arm, so you don't have a remaining difference over time in procedures, and therefore the event rates might over time be similar. What we did in order to see whether the effects were maintained was to use all events during the whole period of follow-up. So patients were censored only at death or loss to follow-up, only a few were lost to follow-up, and we really had as many events as patients because many patients have repeated events over a follow-up of 15 to 17 years. And you can't even compare a hazard ratio anymore after such a long time period because all hazard ratios lose significance over time. And therefore we have evaluated the time gained to the next event by the early procedure. And what we show now with the 15-year follow-up is that the initial benefit that you see over the first 3 to 4 years, it is maintained for life. The curves run parallel after 4 years until the 15th year. And there is a benefit, 1.5 year increased survival without MI by an early invasive treatment. The mortality benefit, though, is not significant. It was only an average of 2 months benefit in mortality, and that was not significant over time. Maybe because of the crossover that all patients with reinfarction will have a procedure. But if we look into also readmissions for ischemic heart disease, there was a substantial gain. So there was even up to 3-year benefit in improved survival without a new readmission for ischemic heart disease. And that went also for all readmissions for cardiac diseases. So there was a substantial benefit by the early invasive treatment maintained over time. We have the ESC recommendations recommending procedures mainly in patients with elevated troponins. Troponins were not available in 1996 to 98. We showed that troponins were useful based on the FRISC trial, but they were not available. If we look into the results stratified for troponin, we can see that the benefits were larger in patients with elevated troponin on admission, while there were no benefits in death and MI in patients with normal troponin. So these results definitely support the European guidelines concerning risk stratification. We also looked into another biomarker, GDF15, which can identify a high-risk group, which had the main benefits. But interestingly also, even patients that were low risk had a benefit in symptoms by the procedure. So there was, even in patients without elevation in troponin, there was a benefit concerning longer survival without readmission for symptoms. So I must say that the early invasive treatment came out very convincingly positive with improved survival without the new need for hospital readmission. Better for patients and maybe also better for the healthcare system, because readmissions lead to new costs for treatment. So it was a very positive outcome for a treatment that is now implemented in most countries of Europe.
Yeah, it's really interesting with this long-term follow-up, and you're talking about the even lifetime perspective. Very interesting. Now, Marco, if you look into these data and you're part of a guideline committee, how do you what is the implications for these findings as they now extends beyond the previous knowledge? How will this be considered in the guidelines?
So first of all, I would like to congratulate Lars and all his team for this really landmark trial, and landmark in many aspects. First of all, it was the first showing that an invasive strategy prevent events. And this FRISC trial is one of the trials we based upon for our Class 1A indication in the 2015 non-STEMI guidelines. But as Lars just mentioned, it's also very interesting, this methodology. So now we are tracking not only the first events, but we are tracking recurrent events. And obviously this is only possible in countries like Scandinavian countries, where you have these registries that pick up any events occurring in this patient population. So I think this trial is really a landmark, and now we have 15 years of positive result, and this obviously strengthened even more our recommendation in the guidelines.
So Lars, what are you going to do with this information subsequently? Are you going to do a 20-year follow-up or a 25-year follow-up, or what's your plans?
I don't think a longer follow-up is needed. What we see is that, I mean, it was only one procedure. The strategy was only while in hospital, and we can see that the event rates are parallel after 3 to 4 years, up to 15 years. And half of the patients, or 40% of the patients, have died. So I think that's enough to know that we have seen more or less a lifetime perspective. Maybe it's also my lifetime perspective on this, because I mean, at my age, maybe when I look back and see something that we did 20 years ago, we can see that this is what we accomplished, what we what we got out of this type of new treatment. There was 1.5 year gain in survival without an MI. There was 3 years gain without need for readmission, and that will stay. What we might be looking into is, of course, could we risk stratify even better? We included 2 biomarkers in the Lancet paper because they have been published before. There are, of course, many other details to look into here. One aspect was that smokers didn't have much of an effect, as a matter of fact, which is fascinating. I think maybe smokers, and we know that they don't benefit as much from vascular procedures as non-smokers. The other area that has always been controversial, it is the effect in women. There was less of an effect in women because of an early mortality in women, and that might be special to this time. We saw the same in the RITA-3 trial, maybe because of aggressively performing CABG procedures in women that were not really indicated. But we will be looking into these details, a gender perspective. But otherwise, I think now we have reached a level of sophistication in our procedures. So a better procedure may be something. What about CABG in certain situations? What about PCI? What about type of stents, etc.? So this is a fascinating story that continues.
Marco, anything you want to add into this?
No, I think it said it very well. So from a guideline perspective, I think there are still area of uncertainty. As Lars just mentioned, is the differential role of PCI or CABG in multivessel disease, because currently we rely only on a trial that were enrolled mainly stable patients. So it is really unknown the differential benefit of the strategy in this acute setting. And the second point I see of uncertainty are the patient at intermediate risk. So clearly now with high sensitive troponin, we define patient that benefit from early invasive strategy. The role of revascularization in patient troponin negative, but with additional risk markers such as renal insufficiency or diabetes, in my opinion, still remain to be assessed.
Okay, thank you for a very interesting lifetime perspective.